Now we're going to start a series of videos that will discuss chronic kidney disease. So now we're looking at a healthy kidney, and so inside of every healthy kidney is 1 million healthy nephrons. And so what you see on the right is the nephron with the glomerulus here, tubules, which all coalesce into collecting ducts. So in a healthy kidney, there's 1 million healthy nephrons, and each nephron is doing a little bit of glomerular filtration. So added together, they all contribute to the collective glomerular filtration rate that we talk about when we talk about kidney function and chronic kidney disease. So each nephron is composed of a couple of main components. One, the glomerulus, which is the filter, and the tubules, which are the tubes. So the way I like to think about the nephron is just a filter on one end and tubes on the other end, and urine comes out at the end of the tubes. And so if we did a biopsy of this kidney, here's what we would see. So the glomerulus looks like this. Under histology, you can see that the capillary loops are patent, they're open. There's a reasonable amount of mesangial matrix here, sort of the glue that's holding everything together, and the efferent and afferent arterioles are patent. What do the tubules look like? So in cross-section, you can see the tubules are nice, close together. The cells look healthy. The tubules are considered back-to-back. They're sort of hugging each other. And there's a little bit of this interstitial matrix in between this peak material. And so this is considered to be sort of a healthy-appearing interstitium with the tubules in place and intact. So you remember our kidney with 1 million nephrons. What does it look like if we lost the majority of them and we're left with something like 200,000 nephrons? So now on the left, we're looking at a kidney with chronic kidney disease. And as you can see, compared to the healthy kidney, this kidney's smaller in size. It's darker, slightly discolored. It looks like it has a coarse, sort of irregular surface to it. And so the final common pathologic manifestation of many chronic kidney diseases is renal fibrosis, which is basically unsuccessful healing of kidney tissue after chronic sustained injury. And it's characterized by glomerulus chlorosis, tubular atrophy, and interstitial fibrosis. So if there's a disease that affects the filters of the kidney, so the glomeruli, this is kind of the end result of chronic sustained injury. So what we're looking at here is the glomerulus, but now it's been replaced by this pink substance, and it's essentially fibrosis, and we call it glomerulus chlorosis. And so glomerulus chlorosis is prompted by essentially endothelial cell damage and dysfunction. You'll see proliferation of smooth muscle cells and mesangial cells, and essentially the podocytes that overlie these capillary loops, they get destroyed. And so when you lose podocytes, you develop proteinuria, and the scarring is eventually what destroys glomeruli that serve that filtering function of nephrons. So in thinking about the tubules and the interstitium, as you can see here, this is a representative image of what histology would look like. You can see there are fewer tubules than we saw in the healthy kidney. Some of these tubules are dilated out, and there's a lot more pink stuff, and so that represents interstitial fibrosis. So basically, tubular atrophy and interstitial fibrosis closely associate with total GFR, especially in CKD. And basically these tubular epithelial cells, if there's chronic inflammation or chronic injury, they can synthesize inflammatory products that basically recruit inflammatory cells into the interstitium. And there's interactions that basically result in ongoing fibrosis. And as this evolves, these injured cells, they lose their ability to regenerate and form new tubules. And as they undergo apoptosis, it causes tubular atrophy, and you're left with non-functional glomeruli. And so this is sort of what you would see in a kidney that has extensive tubular damage and interstitial fibrosis in CKD. Okay, so what then is the definition of chronic kidney disease? And so this is the definition as proposed by KDIGO, so an international set of guidelines. So basically, you have to have one or both of these for a period of 3 months. So if your GFR is less than 60, for at least 3 months, you meet the definition of CKD. Or if your GFR is above 60 perhaps, let's say even 90 or 120, but you have markers of kidney damage. And so here are some of the markers of kidney damage. You could have albuminuria, greater than 30 milligrams per day. evidence of tubular damage, let's say electrolyte wasting disorder that suggests there's tubular injury. Evidence of histologic damage, let's say a kidney biopsy was done and showed tubular atrophy or sclerosis or some other finding, or evidence of a structural abnormality perhaps seen on imaging study, or if the patient currently has a kidney transplant. If the GFR is estimated or measured as being normal, but there's evidence of kidney damage, a patient could also meet criteria for CKD. All right, now we're looking at a CKD staging scheme that was devised by KDIGO. And so, as you can see, there's two axes to this chart. So there's GFR here on the y-axis, and then there's degree of albuminuria as measured by the milligrams of albumin per gram of creatinine in the urine. And so this is how we are currently classifying chronic kidney disease. And so remember, GFR is actually a continuous variable, so it's a number somewhere between 0 and 120 about, right, mil per minute. And so this has been helpful for physicians to communicate to each other, communicate to patients, and also for performing research to have a classification screen where we have sort of these discrete stages. And so the way we classify it, according to KDIGO, is basically if the GFR is above 90 or above 60, with evidence, right, of CKD either by urinalysis or histology or imaging, right, that would be stage 1 if it's above 90, 2 if it's between 60 and 89. If the GFR is between 45 and 59, it's a 3A stage. If it's between 30 and 44, it's 3B. 15 to 29 is stage 4, and if it's less than or equal to 15, we call that stage 5. Next, we care about how much albumin is being spilled into the urine, and so if there's less than 30 milligram per gram, we call that stage A1. If there's 30 to 300 milligrams, that's A2. If it's greater than 300, that's A3. And so the interesting thing about this scheme is that, as you can see, this is color-coded, and it's color-coded based on risk of progression to end-stage kidney disease. And so what we're trying to do is identify the patients who are at risk of getting sicker, progressing to ESRD, needing higher chance of referral, needing more monitoring. And so as you can see, the patients with the most proteinuria, they're at the highest risk, and the patients with lower GFRs are at highest risk. And so that's why this is helpful. Just to make one last point, based on the definition of CKD, so everyone with a GFR less than 60, they meet the criteria based on GFR for CKD. All the patients here with albuminuria, they meet the criteria because they have a marker of kidney damage. They have albuminuria, which means there's some glomerular injury. Whereas the patients here in this group, so they have CKD only if there's some other evidence of kidney damage, either by histology or imaging or abnormal urinalysis. So that's how we think about these different groups and put them together. Another way to use this scheme is to use it to identify which patients should be referred to a nephrologist and which can potentially be monitored by their primary care physician. So you can see patients with the highest levels of albuminuria should be referred to a nephrologist. Patients with GFR below 30 should be referred to a nephrologist. And then, potentially, obviously, every patient's different, but patients with relatively higher levels of GFR could potentially be monitored by their primary care physician. So this is just one way to use this scheme. And so remember, this is just a starting point. Every patient is has their own situation and is different, but this could at least be a starting point for how you think about your patients. How do you determine how often they should be seen, how often they should be monitored with labs, and then how you should refer to nephrology. Supported by the William and Sandra Bennett Clinical Scholars Program and the American Society of Nephrology.